Good evening. Welcome to a special edition of the International Grapevine. This is your host, Wallingford Lee. Tonight in the International Grapevine, we want to talk about a very important subject that I think is very important to certain women or women in general, whether you're a mother, a daughter, a cousin, whatever. We're doing a program about endometrial cancer risk factors. And this is something very important that affects a lot of our sisters and cousins and mothers. And we want to take the opportunity tonight on the International Grapevine to tackle this thing, to talk about it. And we have on our board a special guest that I have dealt with for a long time, a very capable person who I've had the pleasure of working with on various occasions. I'm talking about Dr. Carol McIntosh, which is a medical doctor and also obstetric and gynecologist doctor. She's been around for a while, and we wanted to take this opportunity to talk to her for many reasons. One, she always make a beautiful presentation when she come aboard, and our audience have always asked us, where is she? Why you're not doing anything with her? So we finally found her, and we're thrilled to have her on board. Doctor, welcome to our program.
Miss Lee, it's such a pleasure to be here. Such a pleasure. Thank you again for having me on the Grapevine, and thank you for doing such great work as well. Really, I'm glad to be here. That's
It's
all I
good
can
to
say.
have you. No question about it. It's good to have you. And not only that, having you, uh, we know that you're a go-getter. That and we've worked with you before, and it's a pleasure. And no joke aside, our audience always asks about you. And I was reading a little bit about this, and I said, the best person to reach out to in a case like that, it's you. It took me a while, but I also am thrilled that you accepted the position to come aboard and tackle
Hmm.
this because I think it's important. And welcome to the International Grapevine.
Thank you. Thank you. And I'm glad that you said that takes such time to do this because it's so important. And so many of the programs that you do are impactful and important for our people to hear.
No question about it. No question about it. Not only that, this thing that we're talking about, endometrial, has affected a lot of brothers and a lot of sisters, mothers, aunts, cousin. And I said, let me do a little research and find out. And I said, the person that I would like to have talking about that, it's you. And I said, let's do it. And you accepted, and I am pleased about that. And I imagine that we're going to do the program where you start like in form of a presentation for a good 15, 20 minutes, and then I'll jump in down the road. So the grapevine is all yours.
Thank you. Thank you again. Appreciate it. So again, as Cecilia said, this is such an important issue, and it's an important issue for us as women of color, both our brown and black women, because it is impacting us in such a way. So I want to just jump right into it. I'm going to start off with slides and then come back to just general talk. And those who know me know that I always start with this because we need to start with the fact that we love ourselves and understand that each and every one of us are fearfully and wonderfully made. And I apologize or excuse me, understanding that I'm pulling this from the Bible, but I recognize all faiths, all of us, no matter what. We're to recognize that we must praise who we praise because we are fearfully and wonderfully made. And so let's start first with the anatomy. Next slide. So I'm going to start off with talking about the anatomy. And anatomy really is to just talk about our internal organs. In a future time, we can talk about the external organs, but this is specifically to women. I'm going to talk about uterine cancer, and that's the uterus or what we call the womb or what carries a pregnancy. And the uterine cancer I'm going to talk about is what's inside the lining. So where you see the point to, that's in the cavity itself, which is what develops into thickened tissue to make us have our periods. That's specifically what I'm going to talk about. And I'm going to go over the anatomy and talk about the tubes and the ovaries. Those are attached as well from the ovaries. The ovaries make estrogen, progesterone, testosterone. They also put out the egg, which travels through the tube to the sperm, and then we can conceive if we do become pregnant. And the lower portion of the uterus is the cervix, which is what we see when we go to a gynecological exam and where the pap smear is done, through which a baby is born, if it's born through vaginally, and also when we have our periods, through which blood comes. And the vagina is what connects it to the opening outside. as well. Next slide. So that was a picture. This is the actual. So if I took a camera and stuck it through your belly button, this is what we would see. The uterus, this is what a normal sized uterus looks like. You see the tubes, the white ones are the ovaries. The cervix you cannot see because that's going out through the vagina. But on top of the uterus would be the bladder or the top of the abdominal cavity. And below where you see the yellowish, that's the fat and bowel. So this is in the abdomen of every single woman. And also, if you had to say, am I black, am I white, am I green, am I red, am I blue, whatever, inside we look exactly the same. And I want to point that out, that we all are exactly the same. Next slide. So I'm going to talk, and I'm not talking as a G1 oncologist, I'm talking as your bread and butter OBGYN about cancers below the belt, what affects women. I'm not going to talk about all the different types of cancer at this time. Specifically talking about uterine cancer. As I said, that's cancer of the uterus, also called endometrial cancer because it forms in the cavity of the uterus on the lining. There are other types of uterine cancer that can form in the uterus, but are far less common than endometrial cancer. And I'm not going to deal with those at this time. The early symptoms for uterine cancer are abnormal uterine bleeding, postmenopausal bleeding, meaning bleeding that happens after you're in menopause, irregular vaginal bleeding, meaning bleeding that just occurs perhaps between your periods or after sex or just spontaneously, and pelvic pain. Next slide. So going into it, as I said, endometrial cancer is a cancer of the uterus. And people may say, well, what's the cause? We don't know what the actual cause. We really can't say, but we do know cancer cells that there's a change in the normal cell to become abnormal and to grow abnormally. And I say cancer grows outside of its boundary. And that's basic thing for cancer. So I'm going to start now to talk about what are the risk factors? What puts us at an increased risk for developing endometrial cancer? Next slide. So, again, the symptoms are bleeding. So, what would cause us to have this abnormal bleeding? That would be things that would affect the lining of the uterus to cause it to not stop the bleeding, that would cause it to have changes in its lining. What can those be? One, change in the balance of our hormones. Like I said, we put out estrogen, progesterone, and testosterone from the ovaries. If there are symptoms or signs or diseases that can cause us only to put out estrogen, then the estrogen would start working on the lining of the uterus, building it up abnormally. There's no progesterone to then have us withdraw that lining or have withdrawal bleeding or have our periods. And it keeps building up and becomes abnormal and possibly can become cancer. So that's a change in the balance of your estrogen and progesterone levels. What can cause that? Obesity. If you have a BMI of over 30, and women, I know as you're listening and saying, oh my, look, same here, we do. And we as women of color have a higher incidence of that. If you have a risk factor for diabetes or you have diabetes, that can also cause you to have a change in the bleeding and affect the lining of the uterus. If you have irregular ovulation, that means that you're not ovulating all the time because possibly you're having putting out estrogen. Um, then you can also have increased estrogen that's constantly affecting the uterus. So the uterus is constantly being reactivated or actively making more tissue that can cause be a risk factor for endometrial cancer. PCOS, which I know we all keep hearing about, polycystic ovarian syndrome, which again is you're obese or not ovulating as well or infertile, that can also lead to that. If you're taking only estrogen, and sometimes that can happen if perchance you're postmenopausal and perhaps we're not given progesterone and you're taking only estrogen, or if you have ovarian type of ovarian tumor that causes estrogen, that can be a risk factor. Next slide. So other risk factors also can be many years of menstruation, meaning that you have your periods earlier on. The average age for menses in the United States has been between 11 and 12. But there are those of us that have had starts our period at 10 years of age, or sometimes even 9. And then you have a late menopause. Again, the average age for menopause is 51, but there are women that start to have menopause at the age of 54 or 55. So that means you're seeing estrogen for a longer period in your lifetime, having an early menarche, early menses, and late menopause. Those are risks. Never being pregnant. That again is looking like you're constantly having ovulation. You've never been pregnant, which would stop the ovulation, which would stop the lining from constantly changing because a pregnancy interrupts it. That would not occur if you had not been pregnant. And that puts you at an increased risk for endometrial cancer. Older age. We're living longer, we're being around longer, so therefore things can happen. And so we're at an increased risk for endometrial cancer. Again, the same thing and talk about hormonal therapy. Now, I'm putting this in, excuse the typo, hormonal therapy for breast cancer. This does not say that you don't use it for breast cancer treatment because it's excellent treatment. But for those of us who have estrogen and progesterone positive breast cancer, this is a lifesaver. There's a small increased chance because you're getting this hormonal therapy that you might be at increased risk for endometrial cancer. So therefore, if you have bleeding while being treated for breast cancer, you get that evaluated. And I would also want to say there's the five cancers that stick around: uterine, ovarian, prostate, breast, and oh my gosh, I can't believe I just blanked. Colon, uterine, ovarian, prostate, and breast. Those have a link in the sense that if you have one, you may be at increase for others. That goes into my talking about the genetics, about the Lynch syndrome, which is non-polyposis colon cancer, which is genetically formed. But when you have that, you are at increased risk for endometrial cancer. Others, as you go to the next slide, and I'm going to come back to previous slide because this shows the endometrial cancer, and I want to first talk about other types. Being postmenopausal, as I said, and perhaps not, you're taking just estrogen because you heard that you need to replace your hormones. Those are some of the risk factors. As I said, obesity and diabetes. And they're saying women, Black women, do we have an increased risk? Perhaps, or perhaps it's because we have all of these different things going on that we address it. So we have an increased incidence of endometrial cancer. We have an increased incidence of being diagnosed at a later stage. And that's not because we're Black, but because of the disparities, I think, in medical care. And also we do have a tendency to be obese. So there's some lifestyle changes that we can make. So what do we do? What I wanted to talk about specifically was these are the risk factors that we hear about, and we may be in that. So if you are a person that's sitting there and postmenopausal, meaning that your period has stopped for 6 months, you're over the age of 50, you know that's not your period coming back if you have bleeding. Any type of bleeding after you've been told you're in menopause, or you've been in menopause after the age of 45 or 46 for no bleeding for a year, and you have bleeding again, that is not normal. You must go in to be seen. And I'm going to go through all the different risk factors, but this is a key thing for us to understand. Go in to be seen by a gynecologist to start. Yes, it's good to see your primary care doctor, but we as gynecologists would take it a little further. If a person comes into us who has postmenopausal bleeding, we need to figure out why that's occurring, because you should not have any more bleeding after you've been in menopause. And how do you manage that? How do you determine that? It's by an endometrial biopsy, meaning you take some tissue from the lining of the uterus, which is called the endometrium, for them to look at in a lab to determine why did I have that abnormal bleeding. I cannot emphasize that enough. When you have postmenopausal bleeding, you must come in to see a gynecologist. You must get an endometrial biopsy to determine what's going on. Now, they will do an ultrasound to look at the lining, and sometimes that may be, if the lining is not thick, may say they want to watch it. But for us women of color, really be an advocate for yourself to find out why. Go to a gynecologist for that determination. If you're not postmenopausal and you start to have irregular bleeding, meaning that you have bleeding, prolonged bleeding, and you may also be obese, a BMI over 30 puts a lot of us into the obesity category easily. I am one already. Or if you are been told that you have polycystic ovarian syndrome, meaning that you're not ovulating and you're having irregular periods or no periods at times, and when your periods come, they're very heavy and it seems like it's very prolonged, you want to see about that and evaluate that. Or you have bleeding in between your periods. Your period stops, it's like 7 days. In a week, you have bleeding again for another, say, 7 days or 3 days. And then you have a period again and it's heavy. You want to have that evaluated. Or you have fibroids, large fibroids, which you've been monitoring, but the bleeding keeps getting heavier and heavier, and something else is going on that seems different from what you've been monitoring with your gynecologist. You must come in to be seen and have that evaluated. Doesn't necessarily automatically mean that you would have an endometrial biopsy, but that is the gold standard of care to determine if there's an abnormality, if there's a precursor to endometrial cancer, or if there's endometrial cancer within the uterus. That would be able to determine that because they would take the tissue and look at it. And if they look at the tissue and you have hyperplasia or an overgrowth of the tissue, what they call hyperplasia, just constantly building up, that's a risk factor. And that's something that needs to be watched. Okay. Or if you're on, some of us take hormones, through the herbs, and they're saying, okay, this is probably estrogen like, and you're taking it. Talk with your gynecologist to be clear about whether you should be or not. And if you are, if there's causing the abnormal bleeding. But those are the key things to look at and to be aware of for it. So if you do get diagnosed with endometrial cancer, one of the things that I would say, remember I talked about the symptoms are bleeding, irregular bleeding, postmenopausal bleeding, abnormal bleeding, bleeding between your periods. What's nice about this, and you may say, what's nice about any kind of cancer, is that it occurs early. So that means this bleeding starts at an early stage of the cancer. So that means going in early gives you a higher chance of survival, a higher rate of survival because it's diagnosed and treated immediately. And the last thing that I want to talk about specifically, when you're diagnosed with endometrial cancer, again, you're an advocate for yourself. Do not have treatment with us who are the bread and butter OBGYN. Seek out treatment with a specialist. This increases immensely your survival and the treatment and curing of endometrial cancer. A specialist is a GYN oncologist, a gynecological oncologist, a GYN cancer doctor. That's one who has specialized in that training. That is the person that you would go to for treatment once you're diagnosed with endometrial cancer. So, what are the takeaways? Any abnormal bleeding, go to see your doctor. Any abnormal bleeding, make sure it's a GYN doctor. Postmenopausal bleeding, make sure you have an endometrial biopsy. Diagnosis of endometrial cancer, make sure you see a GYN oncologist. Next slides. So now I don't want to gross people out, but I do want to show this is advanced cancer. This one in particular is not your bread and butter or your simple endometrial cancer. This one is much more than that. As you can see, it's a large mass inside the uterus. It made the uterus large. There are fibroids. Those are the white areas that you see. But this is a large mass that caused postmenopausal bleeding and a lot. And this one needed to come out, and the person needed chemotherapy and as well as radiation. Next one. Next slide. This one as well is another person. As you can see, this is tissue from the outside. And this is a patient of ours. This is after we removed it, of course. And she survived quite a bit of years afterwards. But she came in and had an interesting story. She was, she had a baby, so she had one child. Unfortunately, after she had the child, she had to have a D&C because she had a lot of bleeding. She kept having the bleeding, and this was back in the 60s or 70s or 80s. And the way they treated that was with radiation to stop the bleeding. So they gave her radiation at that time, and the bleeding, of course, stopped, and she never got pregnant again. However, she now came to us postmenopausally with bleeding. And this was what was present. And this is another type of cancer. It's another type of endometrial cancer that was because of the radiation. So that's another risk factor. If someone has radiation therapy for something else, and it can affect the cells long term. Next slide. So, again, the takeaways are lifestyle, improve your nutrition. Diabetes can be treated by a better diet, being aware of our sugars. Obesity can be treated by us exercising and diet. And diet doesn't mean I'm dieting and starving. Diet means just being aware of fresh fruit, vegetables, more of the proteins, less of the carbohydrates or the simple sugars, and exercise to keep our weight well. Keeping ourselves wonderfully made, feeling great can also help to decrease our risk for endometrial cancer. But if we do get it, go in to see your doctor, go in to see your gynecologist, who then will refer you to a G1 oncologist or a specialist. Take care of you because you are fearfully and wonderfully made and have a beautiful temple. And I think, or I believe, and I know that once we take care of ourselves, we will seek out the best for ourselves. If you have any further questions, you can always WhatsApp me at this number. Thank you.
Excellent, Dr. Carol. Excellent, excellent. No question about it. Great amount of information for those who's listening, especially women, and know the dangers of cancer. One of the most important thing in cancer, and I'll say it and I'll repeat it till I get tired. It's so important to get to the cancer early. You have a chance if you can get to the cancer early before it starts taking over your body. How important is that to any patient? It goes without saying. It's outstanding.
You're right. You're absolutely right. And one of the things I want to say is we all know our bodies. I don't care what anyone says. We know what our bodies do. And our body is so wonderfully made. It does the same thing every single day. So if something happens that is not in the ordinary, go in and get evaluated. Don't say, oh, maybe that's not anything wrong. Don't let it go. If you're concerned and the doctor you go to says, oh, let's watch it, go to see another doctor. Go in early. Breast cancer, ovarian cancer. Ovarian cancer is difficult, but breast cancer, examine your breasts. If you feel a small mass, go in and get evaluated. Because all cancer is not a death sentence. And I will say it again, it is not a death sentence. It is something that can be treated and go into remission and be cured. But the earlier you go in and start that battle and you gather up your tools and your warriors who are your oncologists, etc., the better it is for you.
Well, it goes without saying that don't sit on your hands. Go to the proper place to get the necessary help. Well, one of the things that I'm always concerned is that these things with cancer seem to affect us, a lot of our brothers and sisters and Latinos. And I want to ask you a particular question that cover. I mean, we're looking at everyone, but this question that I have, it eats at me. Is there any research been done to understand the biological differences of cancer among different racial groups or ethnic groups? I think this question is powerful, and I hope a lot of Latinos and brothers and sisters are listening to this. It's a key component to talk about.
You are so on point. You are so on point. Exactly. And I'm going to take it in different parts. Yes, there's a biological that we're looking at. But when they look at that and they say, oh, black women and brown women die 2 times as much as white women, it's not something that's in our genes. Because especially right now in the United States, if you look at all of us, we're not 100% black, 100% this, or 100. We are all mixed. So there's other factors that's related. But they do see an increase. Black women and brown women are 2 times as likely to have more advanced disease when diagnosed with endometrial cancer. More than likely, it's probably because they're coming in later. Black women and brown women, there are times when sometimes that cancer has a more biological change in the genes. So the cancer is more aggressive. There's different types of endometrial cancer, and sometimes we have more aggressive, which then decreases our survival rate if it's not treated. How that can be addressed is to making sure that we be seen by G1 oncologists. And lastly, but most importantly, Science. Medicine is based on science and studies, looking at the cancers and how it grows and how it relates to us in our races, etc. We cannot look at how it relates to brown and black women if we don't have brown and black women in the studies. So therefore, when you go in and if someone talks about can you be a part of these studies, please do so because you will provide so much information. Do so with awareness because I'm sure we heard of H. Lack or Henrietta Lacks, and if you have not seen the movie, she's a black woman who had her cells. She had cervical cancer, and they took the cervical cancer cells and they realized it kept growing. That is like unbelievable, the amount of information that they got. They never told her she died. Her family never knew until recently. That's the problem. So racism or implicit bias can be present that causes an issue, but it doesn't change the basis of us being part of the studies so that we know how cancer affects us so then we can find out the cure. So again, there are doctors all over. I hold up Dr. Holcomb and Dr. Chapman, who are with New York Hospital, Weill Cornell, people of color. He is present, has been doing so much work. Dr. Chapman is head of the G1 Oncology Services, and they're doing studies. So if you want to be part of a study where you see a person that looks like you, then sure. But do not be part of it. That is so essential.
I think it's a powerful component you just mentioned to them. This is your opportunity. Don't be scared. It's part of life that can happen to us sometimes. We don't call these things among ourselves. But try to get the
Mhm.
help that is necessary to know just exactly what's going on in your body. Why are you feeling this change? What is going on? Don't be afraid to seek the necessary help. And if you go to a particular doctor and you don't get the right answers, see a second doctor. It's important. It's your body, it's your mind. So get the help that is needed. As we continue talking about this, I'm bringing in another one that I think is very important to you. Uh, what is the endometrial cancer survival rate these days? What is the survival rate in this endometrial cancer type of situation? Is there a survival rate in percentage and stuff like that?
Yes, there are remarkable survival rates if you catch it early. I cannot give the exact percentages, but if you catch it at stage one, meaning that it is still within the body of the uterus, your survival rate is over 90% if you catch it. And how is it? Because you're doing the hysterectomy. If it is something that's shown that is specifically within the uterus and has not spread to the lymph nodes or spread out of the uterus, out into the pelvis, you're cured. And I say it again, you're cured. So, stage one endometrial cancer, treated by G1 oncologists, and it's known to cell that is within, and to remove the uterus and the tubes and ovaries, you're cured.
Well, there's a lot of things happen when you have cancer. What would you say happens to a woman body when she has endometrial cancer? What takes over our body, so to speak?
So, again, it starts off, the first thing it's going to be is you're going to have bleeding. So, we know
Mhm.
we normally have, and a normal menstrual period is anything that's every 24 to 45 days cycle, lasting no more than 10 days, and a normal period. If you start to notice that your periods are heavier and lasting more than 10 days, and heavy, meaning that I've just put on this pad, within 2 hours, I need to change it because I feel like it's gushing out of me. I'm starting, and because you're losing blood and tissue, you're going to start to feel weak. So you're going to become more fatigued and you're not going to be able to do as much. Also, with the fact of having like this bleeding, you just feel ill. You don't want to do anything. You become, oh my God, I can't move. First of all, you can't go out because of the excessive bleeding. That's one base thing. The fatigue that comes with that, the anemia because your blood count is dropping, that's another one. And then from there, you can start having other medical problems because of those. And then also, depending on what was the risk factor, if it is obesity, then all the risk factors that go with that, increased risk for heart disease, etc., diabetes. If you have diabetes, all of that goes with it. Because if your diabetes is not controlled, that's going to increase your risk. If your diabetes is not controlled, it causes so many other things that can happen to you, which is a whole talk in and of itself. Also, You're having heavy bleeding, you're not to be sexually active. Those are the base things. And then if it's more advanced, meaning that it's been occurring at a longer time and your uterus is growing, as you can see, those uteruses that you saw were quite large. The size of our uterus is just the size of our fist. You can have pelvic pain because it's now entrenching and going out into the pelvis and impacting on other parts of the body. As you saw when we looked inside, uterus is small, but if you start having more and more, it could impinge on other parts, increasing the size of your abdomen, and it can spread elsewhere and cause other problems.
Interesting that you mentioned this. Part of my research tells me that some women tend to have their period when they're 12 years old, which I don't think it happened to a lot of women. But what is the difference by a young lady having her period at 12 and some having it at 18 or 20, which we think is the regular age that they should have it? Is there a different
Okay.
component in both situations?
Yes. So the average age for menstruation in the United States is 11 years to 12 years. That's when you
Wow.
start. That's menarche. Okay. And you can start to know for your young girls. That's why you want to talk with them. You can start talking to them about 10 because we do start our periods at 10. Some of us do start it even earlier. Um, my period started at 10 years of age. So that is something where I had to be conscious of that as we're going on to make sure because it's now being, my uterus has been active since then. So it can start as early as 10, but then if it doesn't start before 16 years of age, you want to come into the gynecologist to find out what's going on. If it doesn't start before 18, again, the same thing. So 12, 10 to 16, your period should be starting. If not, you want to come in for evaluation. If it starts as early as 10 and you feel that it's heavy or ongoing, bring your child in because she can possibly have abnormal bleeding from a clotting problem that started the period earlier as well, but it's just bleeding continuously. So the average age is 12. It can be as young as 10. Under 10, there could be an ovarian type of tumor or some sort that will make be a person advanced. So you may see a 7, 8 year old that seems like they have breast and they have bleeding, abnormal, to the doctor.
I like your answer. It also couples with a part that I know for a fact, especially from going back to my age. Young girls at the time don't have a mom or a female person to bring them up to date on what your period is, how to expect it, and how you go about that. I would like to think in today's environment, things have changed a lot. I think the younger ladies now have a mom who went through what I'm saying and know how to
Hmm.
speak to our young daughter coming up in life and saying, this is happening to me. I don't have to hear about it in school. A friend telling me, listen, you're going to have your period. This could happen to you and stuff like that. How widespread that is, or it's more better now in a different circle, a different, better environment that we have today in this world compared to the 40s and 50s, where mom might not have told us certain things and because it's kind of a bit of a shy situation, so to speak.
You're on point. And I'm trying to stay away from the politics for this time when we start talking about how we're banning books and banning what's said in schools because that impacts on that. Where they're saying, well, we're not going to talk about sexual education. It's not sexual education, it's education about the biology of your body. And you are
Mhm,
absolutely
mhm.
right. Mothers, and I include fathers, also need to take the time to tell your child. I'm just going to tell you straight. Yes, I had my period at 10 years of age, and I remember it. It was a Saturday morning. Every Saturday morning, my mother goes grocery shopping. My father is at home. I woke up and I saw all this blood. I went out to my father and I said, "Oh my God, I'm bleeding to death." He said, "Go back to bed and wait for your mother." So I'm like, "Okay, I'm going to go back to bed. I'm going to die. What's going on here?" I went back. He, of course, told my mother because as she came in, she came to me with a set of books and said, "Oh my gosh, I didn't realize it was going to come so early." And she was ready to sit down to tell me everything. Now I'm 10. The only thing I heard from her was that my brothers do not get this, only me. That's the only thing that registered immediately, and I was upset. But she took the time to explain, and that's what you need to do. Parents, I cannot emphasize, you are the first person that your child, there's unconditional love. They trust you. That's why they can jump up on a beam and jump off because they know you're going to catch them. You are not encouraging a person to have sex. and I'm going to say it straight, you will not make your daughter promiscuous. You will not make your son go run out and go have sex if you start talking to them about their bodies at an early age, and talk to them appropriately. You don't have to tell them about the vagina and the I'm saying all this and the penis, etc. But you talk to them when they're bathing. Let them ask questions, and you answer it the best you can. Because when you do, that means when they have other questions, they're coming back to you, and you don't have to worry about when they what they may hear in school or in the songs or in the streets or on the billboards, because you know you have raised your child and given them that they are fearfully and wonderfully made. This is a normal occurrence. Talk to me.
That's great what you're saying. It's called communication, which is a key component. Sit down, talk to your kid. Don't let it be surprised that you get pregnant out there because you never broke it down to her. The good side,
Right.
the bad side, the dangerous, the communication, and about be careful how you've been touched and who and stuff like that. And it's an open situation that in today. I have 5 girl children, and I have talked to them
Mm,
just in the manner that you have talked to them, and I never mixed it. I go straight to the point because I think it's important. Time have changed, and I saw too many things, and I thought it was extremely important to talk to them. And when I did, a couple of them put their head down, and 2 days after, they come in, Pops, you were right. I'm sorry. We were just embarrassed. I said, no, I got to take care of you. And the way to take you is talk to you about these important things that happen in life that, I'm not saying it's bad, but have to know how to carry yourself. That's the key component.
ex-
And it's important.
exactly.
You, you
Exactly.
know,
And when you understand how beautiful your body is, and this is what you want to portray to your children, both male and female, because my father was aware as well. I have no issue, and they made it a point that that I can talk with them about anything. That's what you want. But when you tell your child that you are beautifully made, and that what you have and what you are able to offer to another person, you hold that tight. Bring that person home, because if we all are part of it, then this is great. Because we're not telling you not to, but we're telling you, be clear. Keep to you what is so important and so beautiful in you, and you share it slowly, slowly. Put yourself up on a pedestal, both male and female. Hey, and yes, it's hard to get close to you. Yes, it is, because I'm beautifully made. It is hard. Yes, and I have to take the time and come meet my parents, because they know me the best. And if they love you as well, then something's good here. So, and
you
you
got
want
it
them to
right.
be open.
You got it right. Yeah. One
Yes.
last question. Does going through menopause later in life raises any specific risk for women with endometrial in any way?
Yeah. Yes, so that's becomes one of the risk factors, because you're still being exposed to estrogen, or your uterus is still being exposed to estrogen for a longer period of time, because menopause is later. The average age for women in the United States is 51 years of age, but it's a bell curve, so it can be 5 years earlier or 5 years later. How would you know your age? Talk to your mother, because more than likely, whatever her age was is probably your age. Or talk to your sister. Did you go through menopause? What's going on? And if it is after the age of 51, then you want to make sure that you're going in to find out, am I still bleeding because I'm still pre-menopausal, or am I bleeding because of other abnormalities? And if you're having later menopause, that's okay, because we're living later. But your risks for cardiac disease, etc., once you go through menopause, comes in. And you need to understand, menopause is not abnormal. It is a normal stage. It is the third stage of life. And it is the stage before death. So people say, oh my God, am I going to go through menopause? Yeah. And you will probably be in menopause for a good 10, 20 years, because you're in pre-menarche from age of birth to probably about 12. Then from 12 to probably about 45 or 51, you're in menarche, possibly able to get pregnant, etc. And then after 51, if you live up to 100, you're in menopause for another 50 years. And in African villages, people who are in menopause, they say, oh my gosh, you are now wonderful, because you have had the experience. You're not worrying about now of childbirth or periods. You are now the leader, and we look to you. So this is something to embrace as a strength. There's nothing wrong with being in menopause. There's nothing wrong with saying, I am now moving into another stage. And when people, because I have women that come and say, oh my gosh, I don't know if I want to go through menopause. And I say, well, the alternative, I don't think I want. I think I like menopause.
All right, two things about menopause that we have to keep in mind that's very important. Every menopause is different. Some women get a lot of flashes. Some of them cannot deal with it. In some cases, they can't even go out for 1 or 2 days. How do they deal
Hmm.
with that? How do they compose a situation like that? And what type of help they can get in a situation like that?
Excellent question. So menopause in itself, like I said, is normal. The symptoms that we see of hot flashes occurs in the first part of menopause, and there's a whole process that it occurs, but it's related to the internal body temperature. So your body having the sweats is to bring the heat that is occurring in your body temperature down. So that occurs because the hypothalamus is just going off and causes your body thermometer to go up. So some women, it doesn't bother them. They're fine and they just transition. Other women, it occurs where I call it my personal summer. Like every 10, 3 times a day, I'm like dripping wet and then it stops. But if you take note, and like I said, know your body, caffeine, stress, increased heat, other episodes can cause that. So you take note, alcohol. So take note, why am I having this? And what can I do? Carry a cask, a flask of ice water. When you start to feel it coming up, drink it because that'll bring down your body internal temperature down very fast so that can lessen the hot flashes. Try avoid caffeine. Avoid that person who's at work that causes you a lot of stress. When they start walking towards you, that's time to go to the bathroom. I'm sorry, I got to move. When you're at home, yes, take off everything. The air conditioning is on till it gets too cold, then turn it off. It's okay. That's you. This is what I need to do, then I'm going to do that. But when you start to learn about ways of managing it, you can manage it and understand it's less than 5 years. Now, if it's causing so much difficulty, I can't sleep, this is really making me depressed, that is the time to sit with your gynecologist to talk about taking hormonal therapy for a short period of time to help transition. And there are now other non hormonal medications that can help to decrease the hot flashes or the vaginal dryness because the estrogen is now gone. So there's ways of, if this symptom of menopause is causing a decrease in the quality of life, we can help you transition with that. If it's not, it will pass.
Dr. Carol, unfortunately, we have run out of time, but I want to take this opportunity in behalf of the family of the Grapevine and my audience to tell you thank you so much for
My pleasure.
sharing this information and bringing it out there for our audience to hear and know that there's help out there if you go about things the right way. We don't have words to thank you for all the things that you have talked about that I found that was so important. Okay, because a mother, a woman is the mother of civilization. Without a woman, none of us would be here, and we need to respect the women, care for them, look out for them. And our purpose here on the Grapevine is doing a program like this to help a lot of sisters out there or whoever's here in a program like this. I don't have word to thank you so much again for being our special guest.
Thank you. Thank you for having me. And the fact of you being a male, and I'm not negating anything, but the simple point of the other person with a woman who is the support person, male, female, young, old, however, you too are impacted by this. So you too need to know the information so you can pass it on. And I said, Mr. Lee, you take the time to ask and to make sure that it's known. That is phenomenal because the simplest thing is education and awareness. And that's what we need. Thank you.
No question about it. And again, this is Mr. Lee saying good night for the International Grapevine and hope that you have had the opportunity to watch this program and enjoy it and learn from it. That's what we're all about. We're here to help the community and to our sisters out there. And again, we hope to see you next week at the same time in the same place. Good night.